And welcome to this talk this afternoon on the WHO World Mental Health Report 2022, main messages and implications. And it is my pleasure to be able to introduce to you all Professor Melvyn Freeman, who is an extraordinary professor in our department, and also an expert advisor to the World Health Organization. And by means of more background, Prof Freeman is a clinical psychologist by training and has been involved in public health policy and legislation, as well as health advocacy and research for more than 35 years. And he was the Chief Director for Non-communicable Diseases at the National Department of Health, and before that, the Director of Mental Health and Substance Abuse. And he's held research and consultancy positions, including with the Human Sciences Research Council, the HSRC, and the WHO, and published extensively on matters of public health, including health systems and services, mental health and HIV, youth mental health, and community care. So as mentioned, he's an expert advisor to the WHO and most recently a co-writer of the mental health report that he will be talking to us about today with these main messages and implications. So, Professor Freeman, it is our pleasure to have you here this afternoon. Thank you for making time. And I will now hand over to you. And please just, you can just say next and I will transition your slides for you.
Good, thank you. Well, the pleasure is really mine. Great to be with you all again at Stellenbosch, which is a home for me in many respects, and very privileged to be with you all and giving you some feedback on this 2022 World Mental Health Report. And hopefully, if we've got time, to look at some of the implications of the report for us here in South Africa. But it is quite a long report. When we started out, the director said to me, not longer than 100 pages. And it's now in its current form, although it has got a lot of pictures and it is sort of laid out in quite an accessible way, but it is about 300 pages. And so quite difficult to capture everything that's in it in a short talk. But let me try and see how far we go. So many of you will probably remember in 2001, when the WHO published its World Mental Health Report, New Understanding, New Hope. And I can kind of go into the reasons why it was quite an important and influential document at the time and over the last 20 years. And it's probably been the most quoted document in public mental health over the last 20 years. But it was a pretty influential document. And about 2 years ago, the director for mental health at the WHO approached me and said, look, it's been 20 years since we had such a document. It's time for a new one. Won't you start working on something? Which I did. And since then, a couple of additional people joined the team, and we were eventually a group of 6 writers that put this together. And quite interestingly for us here, 3 of us were psychologists, 1 was a health economist, 1 was a person with lived experience, and 1 was a writer, somebody who could sort of envisage text and put it into nice diagrams and graphics, and a really good writer. And she, in fact, landed up as the first author of the report just because of that very important contribution. But there was no psychiatrist on the report, which I think was quite an unusual thing. But we did have an advisory group of about 20 people and plenty of psychiatrists on that. And the contributors to this report were well over 100 people, including a large number of people with lived experience, giving their narratives and so on. So what I'm going to do is try and take you through what's in the report. And as I said, if we've got time, and hopefully we will have time, look at some of the implications. Okay, next slide, please. Next slide, please. Okay, so what is the story? You will see that the title is World mental health report, Transforming Mental Health for All. And that's really what we were aiming to. Although I have to say that getting to the title was not an easy task. Everybody had different ideas, but transforming mental health for all really is what we were aiming for. How do you go about transforming population mental health? And so it has 8 chapters, and the first 3 chapters look at the what story, the basis for transformation. What are the principles and the drivers? And then chapter 3 has got a lot of data around prevalence and economic impacts and gaps and all of those kind of things. So it lays the foundation for how to move forward. Then chapter 4 looks at the why, the benefits of transformation, and looking at both the intrinsic and the instrumental benefits of transforming mental health. And then chapters 5 to 8 look at the how issues, the routes to transformation. What are the best practices? How do we actually get from where we are to where we want to be? Next slide. So there is quite a lot of text that is somewhat dense, but it is intermixed with a whole number of case studies. And we've got examples from all parts of the world, from low, middle, high-income countries, though most of the examples are from low and middle-income countries. And we really try to say, well, what has been done, where has it been done, and what can others emulate? And then I think in line with new thinking from the previous report of 20 years ago is the importance of the role of people with lived experience in determining their own futures in terms of what should happen, what has happened to them, what worked for them. And there are many narratives also of people with lived experience in terms of the bad things that have happened to them, as well as the good things that have happened to them, that can inform where we should be going and why. And then the report also has various slightly more in-depth, in-focus sessions, which analyzes key issues in promoting and protecting and caring for mental health. So there's an in-focus on COVID, on empowerment, on digital technologies, and these are slightly more in-depth areas. Next slide, please. Okay, so I don't want to dwell on definitions, but I did think that it was important to just look at how the report defines mental health, because I assume that this will probably be now be the definition for mental health that the WHO uses and which many people will use around terminology. So mental health is a state of mental well-being that enables people to cope with the stresses of life, to realize their abilities, to learn well and work well, and to contribute to their communities. Mental health is an integral component of health and well-being and is more than the absence of mental disorder. It's slightly tweaked from previous WHO definitions, but as I say, I don't want to kind of get stuck on it. And then we use the notion of mental health condition wherever possible throughout the report. And it is a broad term covering mental disorders and psychosocial disabilities. It also covers other mental health associated with significant distress, impairment in function, and risk of self-harm. As I say, this could be a talk in itself around what terminology to use and why. Next slide, please. It also defines mental disorder. Next slide, please. And psychosocial disability. Again, next slide, please. But where possible, we've tried to use the term mental health condition because we feel it kind of covers a wide range of areas that we wanted to cover. But when one's looking at prevalence, for example, it is important to look at a more binary approach and look at disorders. So those are important. Okay, so chapter 2 deals with the principles and drivers in public mental health, looks at the determinants, structural drivers, and so on. Next slide, please. Okay, so what are the key principles that drive this report? Well, firstly, and possibly most importantly, that mental health is critically important for everyone, everywhere. And it's integral to our general well-being. Without mental health, people are nothing, really. Whether it's bad mental health or good mental health is with us all of the time. But also, everyone has a right to mental health. Okay. And we then follow the example of the Lancet Commission on Mental Health and Sustainable Development in saying that mental health exists on a continuum and how we experience it changes over time. So mental health is not something that you have and it's the same always for you. It'll shift. Sometimes your mental health might be good, at other times it might be not so good. And it also is through the lifespan from infancy right through to old age, and it shifts. But important in terms of this is that you can have a mental disorder, but also have good mental health. So there's a very nice example from a South African person with lived experience who talks about the fact that they do suffer from schizophrenia, but their mental health is excellent. You know, they take their medicines on a regular basis, and this person happens to now be the chair of the global peer network on people with lived experience, and she's thriving. She's absolutely thriving. So she has a mental disorder, but she has good mental health. And one can look at this continuum in sort of 4 different blocks. But again, time doesn't really allow me to do that. But I hope you've got the message. And I think it's an important one. And mental health is relevant to many sectors and stakeholders. So mental health allows one to connect, to function, to cope, and to thrive. Without those things, what are we? Who are we? Thanks. Next slide. Okay, so this chapter then also starts looking at some of the determinants of mental health. And it's determined by a complex interplay of determinants. There are the individual determinants, there's the family and community determinants, and there's structural determinants. And in each of those, there are protective factors and there are risk factors. And what we need to try to do is identify what those are and enhance those that are protective and reduce those that are risky. And within that, though, we need to look at some of the global threats to good mental health. You know, we can't isolate ourselves from what's going on in the world. Issues like social and economic inequalities, public health emergencies, earthquakes and floods and so on. And then conflict and forced displacement. We all know the mental health impacts of those things, avoidable risks to poor mental health. And of course, we look at the growing climate crisis and its impacts on mental health. And we really make the argument that we might not have the control as people in mental health to redress all of these issues, but we need to make mental health much more of a driving force to prevent some of these things from happening and therefore to increase mental health. We also look at the vicious cycle between poverty and mental ill health and how that exacerbates poor mental health. Poverty does. Next slide, please. Okay. In terms of COVID and mental health, the good side of it, I think, is that COVID has really highlighted to the world why mental health is so important. And we even had the Secretary General of the United Nations, Antonio Guterres, talking about mental health. And the WHO Director General talks about mental health all of the time because you can't divorce the issues of mental health from COVID. How much it's actually changed people's mental health is very difficult to say because it will be different in different times of the pandemic. You know, in the beginning when people were dying, it would be very different from now and so on. But there was shown in certain studies to be a 28% increase in major depressive disorders and 26% increase in anxiety disorders. That was in the first year. But also it's disrupted services quite dramatically, and 44% of countries reported disruptions to their mental health care in early 2022. So it has been a major issue that we can capitalize on, though, in terms of trying to improve mental health. Next slide. Okay. Chapter 3 deals with the epidemiological issues, the prevalence, the gaps, the demands for care, and so on. And I don't have a lot of that information, but please do look at it because there is a lot more than I'm going to present. Next slide, please. So in terms of the epidemiological picture, we are now saying, or the WHO is now saying, that 1 in 8 people live with a mental disorder. I know that at times people have said 1 in 4 or 1 in 5, but the official WHO figure now is 1 in 8, which is itself rather high. And adolescents, it's as high as 14%, slightly higher in females than in men. And then when one looks at suicide, 1 in 100 deaths in the world are from suicide, which to me is actually quite shocking. 1 in 100 of all deaths are a result of suicide. And 58% of those happen before the age of 50. 1 in 6 years lived with disability are attributed to mental disorders, and they account for about 129 million disability-adjusted life years. People with severe mental disorders tend to die 10 to 20 years earlier than the general population, which again is an important statistic for looking at where we go forward and why. Next slide. Okay, so when one looks at the information that we have, we also realize that there are big gaps in the information. But also there are big gaps in the governance. Few countries implement plans that comply with human rights. There are resource gaps. And one of the biggest resource problems is the financial resources that are allocated to mental health. On average, 2% of countries' health budget goes to mental health, okay, which is pretty low. Just by the way, South Africa is probably about 5%, but we can debate whether that's sufficient or not. And then there are major service gaps in the world. Most people with mental health conditions go untreated. The figure that gets put out mostly is that it's between about 80 to 90% of people with mental health problems do not have those problems actually seen to in any way. Next slide, please. Okay, there's also obviously a resource gap in terms of specialist mental health workforce. And on the right, you have the proportion in high income countries per 100,000 population. And on the left, your low income going up slightly with your high income countries. But you can see just graphically how different it is if you happen to come from a poor country or a rich country. And of course, these are statistics that you might want to refer to in trying to build why we need more resources. Next slide, please. Okay. But when one looks at the barriers to demand, I think very often we talk about the main reason being the capacity to see to people's mental health problem, that the gap is because we don't have enough resources available for mental health care. And that is true. There is a poor supply. You know, in most countries, it's unavailable, inaccessible, unaffordable, and of low quality. And importantly, 3% of treatment of depression is seen as, in low and middle income countries, is seen as minimally adequate. somebody did some work and came up with that figure. But we also need to look at the issue of demand. And there is a very low mental health literacy, which leads to people not seeking help. And that's also linked very directly to the stigma issue. So there's lack of knowledge and understanding. There's also different beliefs and attitudes of why people become develop mental health conditions and so on, and what to do about them. And we know many of the traditional beliefs in Africa, in Asia, and many other countries, which lead to people seeking care outside of the formal health services or formal government services. And then, I think people are probably aware that the Lancet Commission on alleviating also came out last week, but stigma certainly is a major issue in terms of barrier to demand. Okay. Okay, next slide, please. Okay, so then what are the benefits of change? Next slide. So we talk about an intrinsic benefit. In other words, having mental health is just good. We don't have to have any other reason to have good mental health other than to have good mental health is good for every person. Why would you not want it? It is in many ways what we all strive for. Why we want a good life, because we want good mental health. But there are also instrumental reasons that having good mental health also benefits economy and so on. It also benefits physical health. So we talk about reduced suffering, and then we also talk about how mental health can improve physical health, and that's, there's a really intertwined relationship between mental and physical health. If you've got poor physical health, your chances of having poor mental health are good, which way, I hope I got that the right way around, and vice versa. But also that if you invest in mental health, your outcomes are going to be so much better from a health and an economic point of view. If you invest $1 per capita annually and you give evidence-based care for certain priority conditions, you can reduce your years lived with disability by about 5,000 per million. Next slide, please. Okay, then there are the whole human rights issues, and we need to prevent those violations. So we need to act against stigma and against discrimination and against abuse, of which there's much. So we have to shift attitudes, strengthen rights, reshape care environments. And we need to give people far more autonomy in decision-making. And there's also quite a lot in the report about how important it is not to simply take people's decision-making away from them if you actually want them to have some role in their own recovery, and feel like they're people rather than non-people. So dealing with stigma, social contact is probably the most important way of dealing with stigma, and through supported decision-making, we can reduce or even alleviate involuntary admission and coercive treatments. Next slide, please. Okay. When it comes to social and economic development, poor mental health puts a brake on this development. Inequality, exclusion really impacts on people's ability to contribute to their communities and to the economy of the country. But it's not just an individual issue. It has to be a multi-sectoral action involving not just the health department, but various departments and NGOs and organizations of persons with lived experience and so on. And we need to start looking also at equitable access to care for people with mental health conditions, and it needs to be at least equal to access to physical health care. And we need to also focus on priority groups, because we know that those are people who suffer from poor mental health more than anybody else. LGBTQI, homeless people, disabled, survivors, migrants, and so on. Next slide. Okay. There's a lot of research now around the economic benefits of intervening with people who have got mental health conditions. And as a rule of thumb, we probably say that for every rand or dollar spent, you get about 5 rands or dollars back if you intervene and you do.
Prof Freeman,
yeah. Yes.
Apologize to interrupt. I think that it might be just poor connection on my side. I just want to check if others are having any connection issues at the moment.
And from my side, this is right.
It's all okay. All right.
Fine where I am, brother.
Okay. All right. Sorry about that. Please continue.
Okay. Yeah. So presenteeism, absenteeism, not being able to be at work, and so on, have major impacts on economy. Next slide, please. Okay, so then chapter 5 goes into the foundations for change. Next slide. Okay, so we talk about 3 kinds of knowledge and commitment that are absolutely essential if we are going to make this change that we feel we need to. So the first is an expressed commitment. There needs to be an expression of commitment to change mental health. And we talk a lot about the value of mental health being recognized and understanding how important it is to put investment, and we're not talking just about financial investment, we're talking about a whole range of investment into mental health if we are going to make changes. But that in itself is not going to be enough without institutional commitment, such as change policies, change plans, change legislation, and programs to realize this. But those together will not be enough without budgetary commitment, and that you actually have to put proper resources. And when we talk about budgetary, we're also talking about financial and human resources that are needed. So one needs all of these commitments to make this change. Next slide, please. Okay. This chapter also deals with the whole issue of task sharing, and for time reasons I'm not going to go into it because I think that we all agreed that this is a critical issue. I'll talk about it a little bit when we get to the services section. Next slide, please. And the report also talks about harnessing digital technologies for mental health. And again, I'm not going to go into all of these things. It's in the report, but as somebody said recently, this is not a choice of whether we want to do it or not. It's with us, and therefore we need to harness and make use of the digital technologies, and it can be used very constructively in the area of mental health in a whole number of different ways. Next slide, please. Okay, then we start getting into how we're going to make these changes. And there's, again, a lot of emphasis in the report on the importance of promotion and prevention for change. Next slide. And here, going back to what I was talking about earlier about sort of individual, community, and structural, when we look at promotion and prevention, we've got to look at how do we help individual to develop mental health capital. How do we help to develop communities, and what structural changes can we bring about? So if we look at the individual, there again, it's not just simply a matter of building people's resilience and so on, although those things are important. But we also know that things like poverty impact on the individual to such an extent that if a person has a mental health problem, then very often it starts impacting on their whole family infrastructure and ability to function, because so much money starts going into buying medicines or to pay for your transport to get to the clinic, that your whole other life starts falling apart in order to keep your mental health together. So, it's very difficult to separate these things out, but there's good evidence now to show that treating your mental health is seen as so important and is so important, but it can lead to breakdowns in your whole family his ability to function. Okay, but we also need to look at the norms, networks, and institutions, and the structural issues to improve daily living and working conditions that enhance capacity and well-being. Okay, next slide. And this is not just, it cannot just be a health issue. Health has got to be involved, but it also needs to extend outside of the health sector if we are really going to be tackling prevention and promotion in a proper way. Okay, next slide. Sorry, I've got far too many slides, and I knew this from the beginning. Yeah. When it comes to suicide, we saw that 1 in 100 deaths is due to suicide. But we now know quite a lot about how we can potentially reduce suicides. And if one takes Sri Lanka, for example, 67% of all suicides in that country were a result of pesticide poisoning. And by introducing a pesticide ban, they actually reduced deaths during from suicide by about 70%. So it's a matter of trying to identify the means by which people commit suicide or die by suicide rather, and role of media and so on. So when one understands as much as possible about the causes, then one can act. And it is then possible to bring huge reductions if one does this based on the good evidence. Next slide. Okay, also around the prevention and promotion thing, obviously, and I say obviously, but it is obvious, children and adolescents have got to be a major focus of your work in prevention and promotion. They say now that about 75% of all mental health conditions start before the age of 24. So if one is going to be doing prevention and promotion, the focus on children and adolescents needs to be there. And again, the report goes into a whole number of different possibilities, looking at things from supporting caregivers to provide nurturing care, school-based programs. There's quite a lot around reducing bullying in schools. And those are really, really important things if we're going to be promoting mental health. You can see that this is quite a broad report, covering so many different areas, but it was necessary to look at it in this quite holistic way. If we're going to say, if we're going to get population and mental health, we need to look at this in a broad way. Next slide, please. The other area that we looked at from a prevention promotion point of view was mental health at work. And there are quite a lot of WHO guidelines that have come out around this. Again, one just came out this month, which is really good. And so prevention and promotion is possible if one actually focuses on the right areas. that have good evidence for them. But we also need a lot more research so that we actually understand this area better. And it is a very under-researched area. Next slide, please. Okay, so then chapter 7 looks at the issue of scaling up care for impact. Next slide. And here we look at a mix of services and supports that are needed if one is going to do good human rights oriented mental health interventions. So we need to look at mental health services in general health care. We need to look at services beyond the health sector. Then we need to look at community mental health services, and we need to look at informal community support. So these intersecting areas are all critical for a model of care which is going to be more or less abusive to people, and where we're going to be able to reach a whole lot more people than we are reaching at the moment. I was quite surprised by a figure which said that the gap between people with serious mental disorders such as schizophrenia and care was as high as 70%. I'm not sure whether that's true in South Africa, but I think we often look at the care gap as being people with depression and anxiety and PTSD, and that most people with psychosis get care. But around the world, it's still 70% of people with psychosis that are not getting care. But this model can accommodate both those common mental disorders and the severe mental disorder. Next slide. Okay, so this is a bit of a busy slide, but I think worth looking at if you do have the time. It's in the report. And the principles are a model network of interconnected services, putting people first. So we emphasize people-centered care, recovery-oriented care, and human rights-based care, and look at community support systems as well. But what is quite interesting is that there is this huge move to community care as defined as anything that is not care in an institution. So, for example, mental health care in a general health environment, even if it's a tertiary health environment, is regarded as community care within this model. But then we look at mental health being integrated with general health care, but also the need for dedicated community care, community mental health care. So there we might talk about things like community mental health centers, psychosocial rehabilitation, peer support, supported living services, and so on. So some of what we are arguing for must be integrated. So it must be integrated into HIV care. It must be integrated into your general hospital care, but you also need your dedicated care. But those two alone are also not going to be sufficient unless you have your mental health beyond the health sector. And there we might look at things like social housing and child protection and prison health services and so on and so on. So this is a bit of a spider's web, but it captures, I think, where WHO think we should be going in terms of our care structure and model. Next slide. Okay, so for community care, and as I said, it's defined as anything other than care in psychiatric institutions. They're really looking very, very hard at the area of deinstitutionalization. This is not new, but it's so important. And yet so many countries, including our own, still have so much emphasis on deinstitutionalized care. We think about 50% of the mental health budget goes on institutional care and about 86% on hospital care, which leaves almost nothing for community, for care in the community. So we need to scale up community services, reduce admissions, and increase care. that's for people with severe conditions, but we also at the same time need to scale up care for common conditions. And some of the things that are probably helpful is digital self-care. There's now quite good evidence for that, non-specialized psychological counseling, and integrated care. Next slide. Okay, I'm going to jump because of time. Next slide. Again, let me jump to the paths to transformation. And this is the last chapter. Next slide. So there are 3 areas that are in the end identified as absolutely critical areas for transformation. And that it's not new what we're saying, but unless we have these 3 elements, we're really not going to change and get better and transformed mental health in the world. And the first issue I've talked about a fair amount, because I think it is really important, is to deepen the value and commitment that we have to mental health. Now, who do we mean needs to deepen the value and commitment? Well, we think it's everybody. We think that individuals need to take their mental health more seriously. Understand that mental health is important. Families need to take it more seriously. Communities need to take it more seriously. Governments need to take it more seriously. And we don't see more resources being put into mental health until governments actually understand how important mental health is to people, to better health, to economic development, and so on. So until they actually understand that value, we're not really going to get anywhere. Then the second area is reshaping environments. We know what impacts on mental health. We probably need more research to know more, but we know so much about how environments impact people positively or negatively. And we need to go back and look at those environments. I suppose we're not that different from what might broadly be called community psychology in many ways, but we need to look at how mental health develops, look at the good things, strengthen those, look at those things that are impacting negatively, and trying to see how we can change those. And then the third area is strengthening mental health care. And that again is not just a health responsibility, but of course, health is very critical in that. And what this report argues for is we do that through strengthening community mental health care. They are saying, the report is saying, we don't need long-stay psychiatric hospitals anymore. They're a thing of the past. We need to transform into good community care. And there are good examples, a lot of examples from Latin America, for example, where they've built community mental health centers. That's not necessarily the only way to go, but it is a good way to go. And that we can give people better lives in communities. We don't need to isolate them. We don't need to shove them away and forget about people. It's wrong. And at the same time, we strengthen our mental health care by trying to focus on anybody who has a mental health condition who can be helped. And we get to people as early as possible so that we can actually prevent long-term problems from developing or problems developing later. So these 3 become the 3 paths to transformation. Next slide. Okay, so I've spoken a bit about the deepening of the value and commitment, understanding and appreciating the intrinsic value of mental health, promoting social inclusion, equity between mental and physical health, intensifying engagement, and stepping up investment. And as I said, investment, when you look at the report, doesn't just mean money. It means investing in a whole new way of seeing mental health and believing in it and doing something about it. So this report really is there to try and inspire people towards change. It doesn't have targets and indicators and things. Those are in the Global Mental Health Action Plan of the WHO. This is to support that by inspiring people to say, right, we can't but deal with mental health. Next slide. Okay, so we've spoken about reshaping the environments, and next slide, speaking about strengthening mental health care. I think I've sort of touched on most of these things, but importantly, we do want to deliver person-centered and recovery approach care and not somebody making a decision on behalf of somebody else. That's gone. You know, the medical model is gone. There are new ways and different ways of doing things. That doesn't mean to say that medical care is not a critical part, but the medical model is something which we really need to move beyond. And of course, all of us who are on this thing have been talking about that for a long time. I think it's quite important that the WHO is saying this now and is trying to move very strongly in this direction. Next slide. I think we're probably at the end. Okay, this is my last slide, and I'm sorry I have taken too long, but it probably is worth running through some of these things. So from before to after, we want to move from limited value and attention to mental health to mental health being valued by all. From widespread stigma and discrimination to equal participation in society free from discrimination. Okay, I'm not going to run through all of these things. Please do read the report. I think these 12 things do capture quite nicely where we think we were before or are to where we think we need to be. But it's not that the world is everything before and we're wanting to go to everything after. There are good examples of the after side also in terms of some of the good examples that are in the report and where we know we need to go. Okay, so let me stop and hopefully we can just have another 10 minutes for some discussion. My apologies for having so many slides and for going so quickly, but as I said, there's a lot in this report. Thank you.
Thank you, Professor Freeman, and I shall give you a round of applause on behalf of everyone online. Thanks very much for covering what is quite a comprehensive report in a short amount of time, and there's lots to say about each of the sections, and I think that you've certainly presented us with sort of the key messages. And I think one in which, or one that I heard in particular, was that by prioritizing mental health for all, it starts with all of us recognizing it at the individual level and taking it from there. So I wonder if any of my colleagues and other guests who are on the call, have you got some comments or questions for Professor Freeman about the report? Please, Leslie, you first. Go ahead. Hi.
Can't stop me. Melvyn, thank you so much. I mean, what a fantastic, and I've just been admiring your slides and feeling like a complete Luddite, and I know you did them all yourself. So,
yeah.
But I mean, what a fantastic, and actually, you may recognize one of the people who's here in the room with me, but I was just saying to my colleagues, this is actually much more bold than the previous report. So, I mean, it's fantastic to see, because the previous report was sort of groundbreaking, but this is actually much more assertive. So, I mean, that's a general comment. But I wanted to ask you something which really worries me, and it's sort of unfair, but I hope you'll be able to help me with this. I mean, all of what you're saying for me holds implications for the training of clinical psychologists, and I do feel concerned, not clinical and other sort of applied psychologists. I feel concerned at that we are not taking sufficient account of the sort of things that you're saying in our training. You know, it feels to me that we have a huge emphasis on sort of the conventional tools of the trade. I mean, you whipped past task sharing. I mean, there are skills involved in task sharing. We aren't teaching those skills. I mean, what would you like to see us doing with the limited resources that we have in the training of professional psychologists in South Africa? Thank you.
Do you want me to answer that, or should I take a couple of questions?
You can go, yes, you can go ahead and answer. We do have one more comment in the chat box, which we will deal with, and that's probably then what we might have time for.
Okay, so I mean, I called this talk, I'm going to report on the World Mental Health Report and implications, and I suppose I didn't really get to the implications and hoped we would have discussion in this, but certainly for me, the implications do involve what it means for training. And, you know, I can kind of give some ideas of what I think would need to change. But I do think that people involved in training should be sitting down with this report and saying, what does this mean for us in terms of what we might do differently? Now, one of the things that the report does talk about is task sharing, as you said, but task sharing also means referring up to people who do have more skills and ability to take more complicated problems as they arise. So it's not as if we're wanting to say that psychologists shouldn't be able to deal with individual psychotherapy on an in-depth basis, okay? Because there are those people that should get referred to them and they should be equipped to deal with them, okay? But at the same time, if we're going to be talking about task shifting or task sharing, who is going to be training those people? Well, first you have to identify who it is we think we need to be training. Is it nurses? Is it community workers? But who is going to be doing that training, and who's going to be doing the support and supervision of those people on an ongoing basis? Well, I think it probably should be psychologists. And you don't just train and supervise. You've got to be trained to train and trained to supervise. So that then should start becoming part of the training of the professional psychologist. We talked a lot about prevention and promotion. Who is going to do that? You can say, well, not the clinical psychologist. The clinical psychologist does clinical work, but I think we need to change that. I really do think that our responsibilities do go beyond individual transformation. I do believe that we have some responsibilities to the country, and there are few of us. Therefore, we need to look at how best we can fit into a transformation of mental health more broadly. So, yeah, I mean, if there is such a discussion in Stellenbosch, I would love to be part of it. But I know that you've been thinking about this for a long time. This is not new about how psychologists get trained. Why is it not transforming to the extent that it probably should be? That might be an important question.
Thank you, Prof. I missed a question from Zora Trafford, who's on the call. Sorry, Zora. But her question is, were there any really impressive examples in the background work for this project of proper investment, both financially and ideologically, from national governments, which do not only put this responsibility on individuals or already overloaded community workers? Zora, if you want to unmute yourself, you could maybe talk to the question a bit more if you like.
Thank you. Yeah, sure. I think it more or less says what I was getting at, unless anything is unclear for Prof Freeman. I guess I just see, obviously, coming from a background of social determinants, this obviously the same conversation has been happening for many years, and I think it's just sometimes it's useful to look at really positive examples, because otherwise it can just feel a bit frustrating. Yeah.
Yeah. So I think it's a very good question that you ask, because I think a lot of the examples are from research projects, for example, where they've done task sharing and they've shown that it works. So it can be done. And you are really asking, I think, what have governments done in terms of sort of major transformation projects? Well, I think that probably the best examples come from Latin America, and especially around development of community care and reduction in institutional care. And in Brazil, for example, over sort of a 10 or 20 year period, the resources that used to go into hospital care were shifted to community care in a very, very dramatic way. And those are the kinds of examples that I think we can be looking at and say, well, why could they do it and we can't? I could deviate a bit in terms of what's interesting is it's also often related to the thinking and transformation of the country as a whole. And quite often it's sort of more liberated governments that are prepared to take the risks for more liberated mental health care, and more conservative governments that tend to get very afraid of that kind of liberatory thinking and think, well, it's best that we sort of keep people in these institutions. And sometimes as governments change, you actually see these shifts ebbing and flowing. So it's not just a matter of a mental health issue, it's a matter of how do we liberate society, of which liberating mental health is part. So yes, there are some good examples in the report.
Thank you, Prof. Freeman. I did see a hand by Francois, but Francois, did you withdraw your hand, or would you like to pose the question? We perhaps have 1 minute left. We are a bit over time, but if you'd like to go ahead.
I think he dropped off the call.
Okay, thanks, Zara.
Yeah, sorry for taking the last minute there. I think you're absolutely right, Prof. Freeman. Thank you for that answer. Another reason why I'm frustrated I can't read Spanish and Portuguese, but yeah, lots to look into there. And also I think you're right about, because the thing I was thinking about is supposed northern leaders in these areas, and it's always this focus on individualized approaches and asking your friend if they're okay and things like that, which is just really not even scratching the surface. So yeah, I think you're absolutely right. Thank you.
I have argued in a response that I did. I was just asked to give a response in World Psychiatry. And one of the things that I say is that this report is actually not going to do much without a whole lobbying and advocacy process accompanying it. And I remember in the last report, there was a large amount of advocacy. I mean, I remember the director for mental health from WHO came to South Africa, and we, in fact, managed to get him to have a meeting with the president at the time, Thabo Mbeki. And that happened quite a lot. And my feeling is that unless there's good advocacy for this report, it'll probably just get onto a shelf and not really have that much impact.
Colleagues, Professor Freeman, thanks very much. We have reached the end. For those of you who have any additional comments or questions, I would encourage you to please get into contact with Prof. Freeman. And yeah, I think within our various circles, we'll certainly be engaging with this report. So hopefully it's not going to be on a shelf somewhere. I think it's going to actively form part of the work that directs what many of us will do going forward. So thank you very much, and thank you, colleagues, for joining this afternoon. And yeah, and thanks very much, Professor Freeman. Thanks again.
Thanks for giving me the opportunity. Thanks for the questions.
Right.
Thanks.
Thanks, everyone. Goodbye.